Today, I want to welcome Dr. John Duldner. He is the data doc and the founder of Connect and Care. There are a few things that I love about John. One is he is a Marine, Semper Fi, John. And
Right.
the other thing is he has a passion for data. And I would say even a third thing is he has a passion for improving patient outcomes. Now, we've had a number of guests on Leaders and Legacies who've been talking about employer provided healthcare and how to make that better for your employees. And John is a part of that, but he works directly with patients and employees for better outcomes. Two questions, two realizations from me in 2021. My two biggest mistakes. One, I realized I didn't ask enough questions. And the second is I didn't ask the right questions. And I wish I'd met Dr. John earlier in my journey. It would have helped me avoid a lot of headaches. And so tune in. I think this is going to be a very interesting episode. Dr. John, welcome and Semper Fi.
Semper Fi. Craig, thanks for having me.
Yeah, it's always fun having Marines on the show. We just get each other. And even I was on a podcast once that's hosted by somebody in the Army, and there's just a different mentality of people that have been active duty. And he said he had people that were messaging him on the show. It was a live show, and they were saying, "How long have you guys known each other?" And we had just met.
Right.
And and that's just kind of the kinship that we have as Marines. And I'm so happy to have you on the show.
Well, I'm honored to be here, particularly knowing, what you went through back in 2021, from the story and then from the book is fantastic and frightening.
Yeah. Well, and that's the thing. One of the things that you talk about, and because I think this is a great place to start, is the whole thing of evidence-based medicine. When we met, you made some comment about evidence-based medicine, and that triggered me because my stepson recorded conversations with the doctors while I was in a coma and dying. And these doctors are like, well, evidence-based medicine, evidence-based medicine. And what struck me was, I think there are three principles, three pillars of evidence-based medicine. They hung on to one, their ego, and abandoned the other two. So, kind of in a nutshell, what is evidence-based medicine?
I mean, to me, evidence-based medicine really is using the best data, but it has to be good data. And again, that's what I mean, the best data to really look at how to treat people, how to screen people for diseases, how to alleviate pain, all those aspects using the most up-to-date information that they have. And COVID presented a lot of issues. One, not just the politicization, but the big thing about we didn't know what we were doing. I mean, I got COVID, pretty much in March of 2020, and a bad, not as bad as yours, but had some complications there with too. And we didn't know what we were doing. There were people who were coming in the ER, which is my training, and within 4 hours we're intubating them, right? Because we didn't know. And at first we were saying, well, we're going to intubate these people early, and then later it changed. Well, we're going to do permissive ventilation, and then if they continue to deteriorate, then we'll go back and then put them on a ventilator. So in those cases, evidence-based medicine really looks at what is that evolution of data that I can make the best decision now. And I can tell you that the evidence isn't always great, particularly for a lot of things, because there isn't enough data, if you will, to actually make a credible decision. And there, physicians have to do what I still believe is a big thing: is there's the art and the science of medicine. And when science doesn't provide you with sufficient background, then to me it's appropriate to work with the art of medicine, which means compassion, which means advocating for the patient and trying to do the best thing you can for them, so that it's a shared decision making. So in those cases, again, with your situation, what would be the appropriate thing to try, knowing that we have to try, right? There's something we have to do. There should have been the art of medicine, not just, hey, this doesn't work, or listen, we're going to stop here. So I think that to me is the biggest deal: is evidence-based medicine has to use the information, but it cannot be separated from the art of medicine as well.
Yeah. And if I understand, correct me if I've got this wrong, the three elements are the data, the evidence, the scientific data is supporting it. The second is what you're calling the Artemis, and basically it's the expertise of the physician and using some judgment and discretion there, which I called ego, but I think in reality it's their expertise and their discretion. And then the third, as I understand it, is patient preference. Did I get that right?
I think so, yep.
So, yeah, the thing that was so bizarre in my situation was they had me on a protocol that had killed 100% of the people that preceded me. And there was no willingness to try other protocols, which were showing up in peer-reviewed journals as efficacious.
Yeah, and in those cases, I don't know if it was, again, I don't make excuses for other people, but you have to wonder what the rationale was, right? And therein, again, it lies with what I like to do, and that is provide that physician side to help the patient or the patient's family to make a better decision, right? So that you're not being bowled over by the system, the institution, and it could just be the physician that was on that day, right? So, we look at physician types a lot like, we talk about the military types, right? So there are physician types and some are better than others. I mean, they all go with the intention of wanting to do what's best. But a lot of it comes to speak to how do I actually do not just what I think is best, but best overall, right? And so whether or not you're talking about equipoise or you want to talk about other aspects of how do I just make sure that that person is getting the ultimate and best care? And if something isn't working, then if it destroyed the lives of 100% of people, then that's evidence against that activity, right? So in that case, evidence-based medicine couldn't have been being applied because it's that Einsteinian theory, right? Why you keep doing the same thing if you're going to get that same result? That's just insane. And in those cases, then you have to start wondering, well, let's do something different or try something different. And I think that's one of the unique things that I like to do is, and when I'm practicing, say we can try this. Here's what the evidence says, but we can try this. Particularly if we've tried the evidence and the evidence isn't effective, then there has to be another approach. And again, that's where case reports start, right? So that you look at how do I treat this, or this is what everyone's been doing. I decided to do something different, and it was a good outcome. That doesn't mean it's evidence. It means it's a case report, a singular event. It could just be a one-off, or there was something else that mitigated that outcome. But that outcome should be looked at and say, well, maybe there was something valuable there, right? And there's hundreds of examples in healthcare where there was one proposed application, but the spin-off was actually more effective than the initial proposal. So, and I think, again, that's where that art and the science of medicine that continues, and it has to evolve. It can't be static, right? So it has to continue to say, okay, this isn't working, or I've got to go here, right? And we do that a lot with the employee data to say, listen, you don't have this, or you need this, and this is how we got to go ahead and get that. And so it's really about providing when evidence doesn't exist, you have to create those data points so that then you can actually manage that outcome in the best way for the patient.
Yeah. One of the drugs that was identified early in the pandemic as potential, and I don't think they tried it except late in the pandemic. I do know it saved a nurse's life over in the UK, was Viagra, high doses of Viagra to treat COVID patients. And I told my wife, I said, hey, if they had given me that, I'm sure I would have sat straight up in bed.
Yes, you would have. But again, you look at the different things about, how drugs work. Really, it's that mechanism of action, right? I mean, what makes Viagra work, right? The phosphodiesterase inhibitors, all these, whatever there are, that, when we look at that virus, and again, the different variants of the virus because of gain of function or whichever, what ends up happening is that, it's biologically something that's occurring that we weren't looking at before, but now we are, right? And we see that with cancer therapy all the time. And a great example is aspirin. Look at the development of aspirin. I mean, that was something that, people would chew the bark and then it would help reduce fevers until someone actually came up with acetyl salicylic acid. We didn't know what it was, right? We just thought it was bark. So in those cases, that development of a known mechanism of action of a medication that is somewhere in the biological pathway that would disrupt the virus or the viral activity within the body or the cells. If we can do that, then we can deploy that, whether or not it's Viagra, whether or not it's, chicken soup or whichever. But again, the reality is that you have to study it and say, hey, if we know this is occurring, again, reverse transcriptase or some other kind of medication to say, if we can affect that process, do we have a drug that's already a, anti-reverse transcriptase medication? Yes, we do. Well, then we can try that. And again, then it's about clinical trials and those things. But it's that, again, that evolution of trying to get the best data to answer those questions so the patients do the best.
Yeah. Well, and something you said a few minutes ago that just really resonated for me was, that you're there to help patients through this, and help them make better choices with their doctors. One of the things that happened to my wife was they drug her in a room with like 15 or 20 doctors, administrators, people with big titles, and she felt all alone in that room. They put a chart up on the wall saying prognosis, multiple organ failure leading to death. And she just felt so alone in that room. And it sounds like some of what you do is take away some of that sense of aloneness, but by equipping them with information so they can ask better questions.
Absolutely. And so, you envision what was going on in that room, right? You have your wife or family members on one side of the table and then the establishment on the other side, right? So there's already this kind of antagonistic approach just from a visual perspective, right? You're staring down the gauntlet of all these people who are wanting to tell you what to do when you're not either capable because you don't understand the medical side. When they talk multi-system organ failure, okay, that sounds bad. People live through it all the time. You're an example. Do I have the right information? Well, are we doing the right things? And so someone has to be behind the patient's family or the patient to provide them with that support so that, I always think back about the old, the talk about, where military leaders would do artificial things to make their forces look larger, right? So they'd be dragging trees behind them, making dust so it looks like they're 10 men is actually 1,000 men. So those are the kinds of things that if a patient has a physician on their side, that automatically sets the level even. And so they know that, hey, I'm going to ask questions. I'm here as an advocate for the patient so that we can actually do that. And so in those cases, that's really the key. You have to be able to take some of that weight of responsibility off of the person so that they can actually breathe and make the decision that's best for them and best for the patient, and not just, hey, this is what we think you should do. Because again, maybe that's not what they should do. And again, in your case, your wife, she did the right decision. So
Yeah. So help me connect the dots. How do you fit in the whole system? I mean, we have doctors, we have insurance, we have hospitals, we have patients. Who writes your checks? Who calls you, and how's all that connect?
So for us, it's the employer, right? So the employer is usually the one that we would work with. And during that time, we then work with each individual. So the employer basically sponsors us to come in and provide complete oversight to their health plan so that we're working with individuals. And we do that, direct with outreaches, our nurses, our care coordinators. And so when they have an issue or a question or need help with something, they have a one call for complete accountability about their health care and their health plan. So the employer brings us in, and we basically do all the work from there. Whether or not we're, a number of our docs, when they take call, if it's an oncology situation, then, then we have our oncology team working on that. So in those cases, it's specifically directed towards a disease as well, so that everything is custom and tailored. And again, based on information that we have from the patient, that we have from the claims, that we have from pharmacy, everything about that, we want to have that data so that we can make, again, that best approach and evidence to what they need, whether or not it's something that, hey, we've got a 52-year-old male or female that hasn't had their colonoscopy, right? They have no other risk factors, but 5 years ago it was 50, now it's gone down to 45, so that we know we can get that. And then again, whether or not the person says, I don't want to colonoscopy, well, that doesn't mean we don't test you. Maybe we can look at fit testing or other kind of opportunities to try to survey whether or not cancer is there. And so again, being able to use that information, but still working with that individual to provide them. So again, we can come in on a lot of different ways, whether or not it's from a third-party administrator. So there's a lot of ways that we can come in, but ultimately, our goal and has always been helping that individual employee slash patient slash consumer of healthcare. So, and that's really where it's at, whether or not it's, the husband, the wife, the children, we take that whole individual approach.
So what's the incentive for organizations, for companies to, attach you to their health plans?
So I think it's massive, actually. So, the three big things are cost savings. So, if we look at a plan, we look at the data and say, hey, you're overpaying here, or hey, you're paying way too much on this medication, or listen, why there's no reason you should be paying $66,000 for a knee replacement when those can be directly sourced through direct contracting or otherwise, for more than or less than half of that. Or cases that we just reviewed a plan and the plan actually paid, this was actually already paid, $9,464 for an EpiPen. Actually paid it, knowing that, yeah, we can get that for $253 over at the local pharmacy. So those are the kind of cases where, we use the data to save the plan money. From the patient perspective, we provide care navigation, advocacy, everything they need along that journey to make sure that, the navigational buoys are narrow, and we know the channel that we're taking. So it's not, hey, I'm taking I'm setting sail on the ocean and I don't know really where we're going, and our compass is broken. So we provide that healthcare navigation at that patient level, which is again what we've been talking about. And the third aspect is it just looks in terms of being able to cover quality and outcomes. And so saving money, you see a lot of people, hey, I saved this plan $300,000. Because you saved the plan $300,000 doesn't mean that people got better care. Again, health insurance doesn't mean health care. So in those situations, it is about saving money, but it's really about making sure that the quality and the outcomes are there. Because if you're just doing something, not just the financial outcome, now that's good for the employer, but it's not good for the patient if you're spending that money, even if it's less, and they're not optimizing the care they're getting. So, managing the plan cost and reducing those, helping the patients, and then making sure that the outcomes really are data and evidence driven so that everyone is benefiting from this. And it helps year after year from costs and recovery, and again, making sure that the patients are healthy, which then also makes it easier to retain employees, right? You talk about jobs and things like that, employee benefits are a massive consideration for Gen Z, Gen X, every generation, because when you start looking at, hey, what are the potential healthcare costs? I have to have a way to cover those.
Yeah, and I think, based on some data I've heard, as we approach 2030, the number I've heard is in 2030, 70% of the US budget's going to be service on the debt, Medicare, Medicaid, and Social Security.
Yep.
70%. And so at that point, we're going to have to do something different. Something will have to change. It's the prices of healthcare are just so inflated, and I don't believe they have to be. I don't believe they have to be as inflated as they are.
No, they don't. There's a lot of opportunities. There's the traditional kind of insurance. It's the same way. We've been buying cars the same way for a long time. And then we look at a Carvana that comes up. We've been buying healthcare the same way since it feels like the dawn of civilization, or at least the dawn of healthcare. There are opportunities to do a better job. But again, it's just not about that final cost that, hey, I can save X number of dollars. If the people still aren't getting better care, then the savings are great, but we're still missing the point of why we've been providing health insurance and coverage for patients.
Yeah. Well, as you were describing what you did, there was a slice of it that sounded like what pharmacy benefit managers were supposed to do. And this is still sort of a new concept to me, that pharmacy benefit managers were conceived to help make sure the patient gets better healthcare and doesn't overspend, doesn't get addicted to drugs. But from what I can tell, they've just become a massive shell game for hiding profits, so the big insurance companies can meet their profit ratios.
So, it's funny because, the law was formally passed in 2021 with the Consolidated Appropriations Act. 10 years ago, 15 years ago, the ERISA laws on the retirement products went through a massive overhaul. Well, that was kind of the intention with the Consolidated Appropriations Act. And that's put a lot of responsibilities with the fiduciary duty on the employers. The problem is, and I think the best way to describe this is that there's a fairy tale in healthcare right now, and it's the emperor's new clothes. So you've got the employer who's the emperor, and you have everybody else who services and serves them to say, well, I've got the broker, I've got an advisor, I've got a pharmacy benefit manager, I've got all these people, and they're all telling the employer, you are beautiful. Your plan is perfect. We're doing this for you. We're looking out for all these other things. And then you have people like myself and some other people in the industry that are basically putting our hands up saying, hey, you're naked and you're overweight and your knees look like they're buckled. There's all sorts of things that we're coming in and saying, listen, all these people who are telling you these things, it's completely inaccurate. And again, we're using either data or other mechanisms to do it. The problem is the employer is the first one that has to take that step and recognize maybe there is a better way, and maybe I shouldn't actually believe in these people, because this is, and I fight this on a day-to-day basis, with the business, because people say, oh, my broker says they're covered. I said, well, why don't we put your money where your mouth is, and we'll do, and I like your comment about an irresistible first offering. It's like, we'll do a data analysis for free. If we're wrong, we actually make a donation in a veterans-based charity that we support. It's like in your name. So $250 goes to a veteran-supported agency or organization if we are wrong. And we haven't been wrong yet, but we still make some donations anyway. But the important part is that employer has to recognize that someone is telling them, or they're looking in the mirror and actually recognizing themselves that, hey, they're not covered with beautiful robes and all these, adornments. They really are naked, and they're missing on their fiduciary duty. They're not compliance with, they have no compliance with gag clause. Their RxDC reporting is completely unused, and it's being shelled against them, so they don't see some of the pharmacy rebates that they should be getting. And again, that it's ultimately their responsibility. You look at some of the lawsuits that have come up for breach of fiduciary duty by the employer. So, and the prediction that these are all going to keep going up in 2025, and I don't disagree, because there are those kind of organizations that will eventually say, hey, I'm not doing what I'm supposed to. And we come in and we try to help with that, because that allows us to say, listen, you're now in compliance because we're taking a look and we're taking care of all these things that you weren't doing before.
So in simple speak, what was the fiduciary duty? What's that mean? That's a big phrase. What's that mean for the?
Yeah, and it means a lot in different things. So, investing fiduciary, but in the healthcare fiduciary, they're supposed to act in the best interest, the plan is, of their members. So all their employees are supposed to be receiving the best, I guess, for lack of a better description, the best outcomes and the best stewardship of those healthcare dollars. So they shouldn't be paying $9,646 for an EpiPen, right? That right there is a breach of fiduciary duty, and is something that someone can file a suit against, because not only is it's a self-employed plan, so the employer pays one component, but you have to remember that the patient still has a deductible, and so until that deductible portion on that's met, it's an outlay for them as well. So anytime where the plan is not acting in the best interest of its membership, there is a breach of the fiduciary duty. And this is happening all the time, and all the brokers, advisors, and all these other organizations who are allegedly supporting the employer are not helping them. They're actually hurting them in the fiduciary space.
Well, and from what I've read, it's a fairly easy mistake to make. I mean, my goodness, Johnson and Johnson, a very sophisticated company, breached their fiduciary duty, and they got in what, a $20 million lawsuit.
Yep. And it was over the cost of one drug. And so, again, that's why you use the example of the EpiPen, because that plan is at high risk if the employee would find an attorney and say, hey, I want to sue about this, and they would have a case. So, and even if they don't have the case, or the case gets settled out like a lot of them, it still occurs we haven't seen a plan yet that is functioning above. And again, we have what's called a clinical claims assessment score. We look at either 10, 15, or 20 metrics. We haven't seen one hit above 37 out of 100. And again, that takes in consideration pharmacy, it can take in medication therapy management, screenings, and all sorts of kind of things. And so this is why when we look at and try to help an employer to say, here's the data and here's what is the problem. But at the same time, we're not just saying, here, here's your problem, we'll see you next year and we can redo this again. We actually come back and say, here's the problem, here's the solution. And again, that's the Marine Corps way, right? We don't just say, hey, we recognize, hey, there's the enemy, the mission of the Marine Corps Rifle Squad, right? Locate, close with, and destroy the enemy by fire and maneuver, or repel the enemy's assault by fire and close combat. So, you still look at, 40 years later, right? Still in the back of the head. But there it goes, right? So that we know what the problem is, we know the solution, we're going to implement the solution, and we will be victorious again for the plan in this case, because that's really the idea. What we have to do for them, because again, most people in the business world, they know their business. They're not in the business of healthcare, which is the whole reason why they enlist the help of a broker and all these other kind of people that are, again, all the people who are telling the emperor or the empress that they're not, that they're beautiful, and they're really not.
Well, I love your example about the Marine Corps, because in healthcare, it feels almost like Chesty Puller in the Chosin Reservoir, where you say, hey, the enemy has simplified our problem. They've surrounded us. We can shoot in any direction.
That's right. Yep.
So, wow. Well, I heard something there. So as we wrap up, I think there's something very actionable that just seems like a no-brainer. You have this assessment for $250, which is, I mean, that's nothing, where you'll look at somebody's plan and see if there's a gap. And if you don't find any problems, a veteran gets a donation. If you do find problems, they start working on the path. So they're meeting their fiduciary duty, their gag order. You listed off a whole bunch of things that still make my head spin, but they're at least on that path to making things right.
Absolutely.
So how do they get that? How do they reach you?
So, they're obviously, on LinkedIn, they can find me there, connectingcare.com is where to go, or they can actually call, 440-829-7562. So any of those ways, we'll be happy to help.
Excellent. Excellent. Well, Dr. John Duldner, sorry, this has been outstanding. And, I think there's a lot of actionable information. I wish my wife had known you in 2021, because she would have had a lot of questions and you would have helped her through a really tough situation.
Well, I'm sorry she had to go through it, and obviously what you had to go through. But yeah, that is really, one of the mantras we have with Connecting Care is it's like putting a doctor in the family, right? Not everyone's that lucky. And I look at the genesis of Connecting Care was the bad care my father got. So I diagnosed him with cancer. I couldn't get him in to see somebody. No one would call me back about test results, all sorts of things. There were 17 errors in his care. And again, as a Marine, as an ER doc, I don't have a small personality. I mean, we live life, and that's why there's a lot of shows about ER, right? So we have that ability and that need to be able to control situations. But if I get bowled over, then 99% of people are getting bowled over. And that's the mission, really, is to avoid that happening to people. So we try to put a doctor in the family so that, even if you have a doctor in the family who doesn't want to get involved, or again, we work with, it's making those decisions easier for people based on evidence and based on, what we think is best in those situations. And we may not know. And again, there's the art and the science. So.
Yeah. Well, I hope people reach out to you and take you up on your offer. That sounds like an incredible offer. Thank you for being on Leaders and Legacies.
Semper Fi.
Semper Fi.